Morning everyone, I am Dr. Mohit Chaudhary. This is TransConnect February 2025. The topic for the today is Beads of Insight, Unraveling the Compatibility with Luminex based bead assays. So what is compatibility testing? It is basically a set of tests performed pre-transplant to assess the compatibility between the recipient and the prospective organ donor. And what is an alloimmune response? It is the recipient's immune system recognizes the donor organ as foreign and mounts an immune response. That is the alloimmune response. So what are the goals of compatibility testing? First is to reduce the graft rejection, very important. Optimize donor selection, ensure that the selection of the most compatible donor is there. Personalized transplant medicine, we can have tailor-made immunosuppressive regimens and improve the patient outcome. Eventually, that is the main goal. So graft survival, we all know, is dependent on donor-specific antibody. Graft survival, if you see, if you have a preformed DSA, whether it's a third party or de novo DSA or a non-complement binding DSA or a complement binding DSA, all have an impact on the graft. And more often than not, whenever you have a DSA, it leads to graft deterioration. So what are the tests available for combating this graft dysfunction or acute humoral rejection? We have the following tests. We have the antibody screen or the PRA, which is both qualitative and quantitative. We have the physical cross matches like CDC cross match, Luminex cross match, flow cross match, and we can also do a virtual cross match by single antigen bead assay in the patient antibody status and donor HLA typing to have a virtual cross match. Also, there can be non-HLA antibodies which may be implicated at times. So Luminex based bead assay, just a small brief introduction about it. So it is a multiplexing technology which has got colored coded beads for simultaneous detection of multiple analytes. So basically what we are doing is it has an application in transplant compatibility testing, antibody profiling, and disease biomarker detection. So what is the principle? So basically what you're doing is the sample is added, that is the analyte is added to a mixture of color coded beads. Beads are color coded in different dye proportions and that will give unique specificity to each bead. So now this sample is added to the mixture of color coded beads. Now this pre-coated with analyte specific capture antibodies. So there is an antigen antibody reaction. So basically what is happening here is you have this Luminex bead and this has got the capture antibody with it, which is against the target analyte. So once it combines with, if there is a target analyte that is present, this capture antibody will capture the analyte and there will be an antigen antibody complex that will be formed. Now then you need a detection antibodies which will actually make a detection antibody to this target analyte. There is a fluorescent tagging to this detection antibodies. These are biotinylated detection antibodies specific to the analyte of interest, and they are for detecting this antigen antibody sandwich. So they are generally phycoerythrin and streptavidin labeled, and this fluorescent tagging will give you the fluorescence when it passes through the luminex. So once that happens, there is a signal detection. So beads are read on a dual laser flow based detection instrument such as Luminex 200 or Luminex 100. And basically the red bead is the one that classifies the beads and determine that the analyte is being detected or not. And green laser actually tell you the magnitude of the signal, that is the phycoerythrin derived signal. So basically red will tell you the specificity whether it is HLA A2, B1, B51 or whatever. And green laser is going to tell you the intensity or the amount of fluorescence that is there, which will determine whether it is a positive or a negative analyte. So very important test. First test that we should know is PRA. PRA means panel reactive antibodies. Basically, we use a Luminex based PRA because it is very sensitive, and this has an antigen coated beads to detect the HLA specific antibodies. The significance is it indicates sensitization to level in transplant candidate. Higher the PRA, higher immunological risk, and it assesses sensitization by determining presence of pre-existing HLA antibodies. Guides immunosuppressive strategies for sensitized patients. So we have two types of PRA screening. First is a quantitative PRA screening, basically means the strength and the percentage of HLA antibodies reported as a percentage, and it is more precise. You can also have a qualitative antibody testing, which detects the presence or absence of HLA antibodies Whether they are donor specific or non-donor specific is not determined. You will just report it as positive or negative, indicating the presence or absence of antibodies. So it gives a limited information. Nonetheless, that information is very important when you put it in the right perspective. So PRA results are always expressed as a percentage. Now what PRA actually does is it gives you a stratification into low, moderate and high PRA, which will tell you how much the patient is sensitized, whether less than 20% is low sensitization, 20 to 80 is moderate sensitization, and high PRA is when you have greater than 80%. So this is how the PRA qualitative antibody screen results look like. You can see that. Uh, so you can see there are class 1 and class 2. It is divided into two. So there are 7 beads on blend of 7 beads, beads in the class 1 and 5 in the class 2. You can see that the cutoff value is 1000. Raw value is greater than the 1000. You get a score. So whenever it is less than this raw value is what you see. If it is less than 1000, it is negative. This is the positive case in which you can see that there is a values of greater than 1000 in all the beads. So even if one bead is positive, it is considered as positive. So this is the HLA class 1 and 2 positive result. If you see PRA, it gives a different kind of result. You will get the specificity all of the antibodies that have come positive. So you can see that it is positive. This patient is positive for DQ antibodies and negative for all these other antibodies. And the PRA here is expressed as a percentage, which is 93% here. So coming to Luminex crossmatch is another modality that we perform, and this is basically done to actually you have a Luminex based lysate crossmatch in which you have to generate a lysate from the donor cells. And how do you do that? You add a detergent to the donor cells, and that's how the HLA inside the nucleus will come out. Now the HLA is now bound to the capture antibodies. Now these capture antibodies with HLA acts as a donor antigen, and from the patient you take the serum, that is the patient's antibodies, and then there is a they are mixed together and they are detected through a secondary antibody like we have in the red cell serology as well. So basically it's a cross match which utilizes the lysate to have HLA being captured by the capture antibody and then detected. If there is an analyte present, it is detected by the secondary antibody. So this is how the worksheet looks like. You can see we always put a lysate control reagent whenever we do a run, and that is done basically to see if your lysate is working fine or not. So if your lysate is working fine, then you can say that this is one of the quality checks that you perform. So these are the test samples in this case, and these are the lysate control reagent. You can see this is the raw value like we see in the antibody screen. We see the raw value here, and the cutoff value is 1000. These are the adjusted values to look for the background based on the cons value, that is the background value. So based on your adjusted values, you can also determine whether there is a background or not. So this is the positive control and that is the negative control. So this is how the positive case looks like. You can see that the raw value is 5400 and the adjusted values are all above 4000 or something. So this is a class 1, class 2 positive case greater than 1000. If you see the next one, this is the raw value is 141 and 137 in class 1 and class 2. So you can see this is a negative case. So this is how it looks like. This is the paper that we did on Luminex donor specific cross match. We called it the good, the bad, and the ugly of the Luminex donor specific cross match. We did 325 patients for Luminex cross match, HLA antibody screen, and CDC, and we found that CDC cross match was positive in 3%. Antibody screen was positive. Luminex cross match was positive both in 24 cases. Antibody screen negative, Luminex cross match negative in 275 cases. Antibody screen positive and Luminex cross match negative in 22 cases. But the the part that I wanted to highlight is that there was 4 cases in which actually antibody screen was negative. That means there was no antibody, but still a Luminex cross match was coming positive, mostly in the class 2 antibodies. So this was confirmed by single antigen bead assay and we found that it was negative. So yes, this is the paper that we published. This was published in 2018 in HLA, and we had actually done 754 cases, but 325 cases we did for CTC crossmatch, Luminex crossmatch, and antibody screen. So what did we learn in this? That that it is a very high sensitivity for DSA detection. This test doesn't require viable cells. It is a very rapid test, provides MFI value for real-time monitoring. You can actually monitor them, and lysate storage can happen up to 1 year. So we can store the lysate, and even for a cadaver or a cadaveric transplant and all, when you require the donor cells, it is very handy at times. The bad is that it gives false positive. Obviously, we have discussed it's more in class 2. So you need to be wary of that. That's why it cannot be employed as a single test. It requires additional confirmation with SAB assays. Limited, it does not detect DQ and DP antibodies. So if you nowadays DQ antibodies have a very wide role and they are coming also implicated in a lot of cases. In those cases, you have a limited detection in DQ and DP antibodies. Luckily, it cannot be used as a standalone test, and you should be doing another other test with it to have a better understanding. So what is a virtual cross match? This we have discussed, but just to reiterate, it is a technique which very sensitive, as sensitive as flow cross match, and it gives you the specificity of antibody. Virtual cross matching refers to the comparison of the HLA antibodies in the recipient and HLA typing of the donor, and you virtually cross match it to know whether there is a cross match is positive or not. So it is done basically on a single antigen bead assay. This is a Luminex based technique in which each bead is coated with one HLA antigen. So that gives you a precise specificity profile of the antibodies against the HLA molecule. It is a gold standard for HLA antibody detection. It is the most sensitive and most specific test that is available. So generally we keep a MFI of less than 1000 as negative and more than 1000 as positive. And this you can even stratify based on the MFI, whether it is 1000 to 3000, it can have a low moderate binding, greater than 1000 it is 3000 it is a strong binding and can be high MFI values. So this is how the graph looks like. You can see that it is a single antigen bead assay, and you can see that the risk stratification is also done. The ones in the red are the ones with the high MFI, then the moderate amount of MFI, and then these are the negative ones. This is how the sheet looks like. You can see that the donor typing is HLA DQ beta 1 0501 0303, and you have the same antibody in the patient. So that is a donor specific antibody with an MFI of around 11,693. So clinical implication of SAB is presence of high MFI DSA. You can do it pre-transplant detection, and that will tell you the rejection risk. You can even do a post-transplant risk assessment, wherein you can adjust the immunosuppressive regimens. You can see the persistence of high MFI DSA, look for desensitization, predict the poor long-term graft survival, and close monitoring depending upon the SAB implication. So yes, SAB is a very sensitive and specific test, but then it has got its own problem. It is most importantly, it is a semi-quantitative test. The MFI is semi-quantitative. It's not an absolute value. It is dependent on a lot of factors, uh, and that which we'll discuss a little bit. Proson phenomena. There is antigen density, CNDQ, conformational changes, cryptic antigens, epitopes may be exposed. There may be epitope sharing. There may be modification between the lab locus and reagent lot specificity may also differ. So it is a semi-quantitative output. Numeric output of Luminex SAB is trimmed MFI. So the lab actually validates it with the other labs and also with the test that they are employing, like a sensitive technique like a flow crossmatch. So you have your own MFI cutoff level. Some may keep it as a liberal cutoff, others may be more conservative in the MFI output. So this, yes, it's a semi-quantitative output and dependent on many things like you should have the adequate antigen and antibody ratio. You should not be having any interfering factors or epitopes which are shared in between. And sometimes you may have a prozone in which you have either the antibody excess or an antigen excess, which may not give you the right value. So sometimes when you dilute, you may get a zone of equivalence, and that may lead to the positivity. So yes, we also had a case in which we had a positive virtual crossmatch with negative flow crossmatch. We actually went on to look for it, and we found that there were cryptic epitopes which are there because it's a synthetic test. There were cryptic epitopes that were being that were coming positive, and so we denatured them. So we had to do a lot of treatment with the HCl and all of that, and we found that those were cryptic antigens, cryptic epitopes, and that's how we were able to actually explain for why a virtual crossmatch was coming positive, whereas the flow crossmatch was negative. So this is a checklist between the cross-matching methods. All of them are required. CDC crossmatch is very, very specific, not so sensitive. Flow crossmatch is very sensitive and specific. Luminex based assay, of course, you have a Luminex equipment, then you can go for Luminex based assay. And of course, the gold standard is the virtual crossmatch using the SAB assay. To recapitulate, we have antibody screening, both qualitative and quantitative. Cross matches, we have CDC crossmatch, flow crossmatch, Luminex crossmatch, virtual crossmatch, and a lot of tests to be done. So the treating clinician does not know what to do, whether he goes in this direction or that direction. So basically, there are too many options and how to choose. We need an algorithm. So we do not have a single test that is 100% accurate and sensitive. Testing algorithm increases the sensitivity, and there are several algorithms that are available, like several approaches in the different part of the world, like Basel, Leiden, Minnesota, and so all of that can be recapitulated. We can do it here, but we don't have our own algorithm based on the settings that we have, or the factors that we have in this part of the world. So this is the Basel approach, in which virtual crossmatch is done upfront. So they do a single antigen bead assay. Similarly, in Leiden also, in the algorithm, you will see that the single antigen bead has a topography which is higher. And similarly, in Minnesota also, the single antigen bead assay is done upfront. So these different approaches have been done in various algorithms, and most of them have a primary test as a virtual crossmatch. So we went on to look for another separate algorithm because we wanted something from India, from this part of the world. So this algorithm which we employ is known as Delhi approach, and we did a multicentric study between few hospitals. And so in this study we found out that combination of two tests will actually give us a sensitivity which is much higher, and we can actually resort to single antigen bead assay later when one of them comes positive. So this is the the multicentric study, and the sensitivity and specificity of the pre-transplants. You can see that the CDC crossmatch is very specific but not so sensitive, and similarly other tests like flow crossmatch are relatively sensitive and specific. You have the antibody screen and the combination of class 1 and class 2 antibody screen. So when we went on to look for a combination, we found that the flow crossmatch with antibody screen gave a relatively good coverage in everything. And we found that the combination itself could take care of most of the tests. What we employed was that we should do a algorithmic approach rather than, going for a single test here. So this is what we suggest. We do a CDC crossmatch upfront. If it is negative, we go for antibody screen along with Luminex crossmatch and flow crossmatch, one of the two. If both of them are negative, we go ahead with the transplant. However, if one of them is positive, then we do a virtual cross match and look for desensitization if it comes positive, or a paired kidney exchange. So if that becomes negative after desensitization, we go ahead with the transplant. Of course, to deal with single antibody greater than 10,000 or multiple antibodies with greater than 5,000 MFI, it is a little difficult, but nowadays we have even dealt with antibodies of higher than 10,000, and we have successfully desensitized the patient, and patient has gone ahead with the transplant. So way forward, there is no single test, cell-based or HLA bead-based, which is 100% accurate. CDC is still performed. Other cross-match techniques are adjuncts. The advent of flow cross-match and Luminex assays has allowed the direction of low titer but potentially clinical relevant anti-HLA antibodies. Virtual cross-match or SAB assay is not the final answer. It should be performed wherever necessary, but we should use a testing algorithm, and we have our own Delhi approach algorithm for antibody testing. If it suits you, you can always employ that. Thank you so much for your kind attention.